Welcome to our live webcast, Lumbar Spinal Stenosis, Exam, Diagnosis, and Minimally Invasive Approaches. We will talk about mild, Vertiflex, and endoscopic decompressions, and we'll also talk about SI joint fusions. Thank you for joining us tonight. My name is René Priscora. I practice at the University of Florida in Gainesville, and I'll be serving as the moderator for this webinar. I'm also joined by our speakers, Dr. Nick Canzanello. He's practicing interventional pain medicine at the Mayo Clinic in Rochester. And also we'll be joined by Dr. Matthew Maroney, Dr. Sanjeev Kumar, and Dr. Amir Jafari from the University of Florida in Gainesville. The process of this webinar will be that we're going to have a live Q&A session, which we will have at the end of all of our presentations, so please stay tuned. Feel free to use at the bottom of your screen the Q&A icon and place any questions you might have in there, and at the end of all of our presentations we will address those questions. Some questions we maybe even answer during the presentations in the chat box. Again, thank you very much for joining us, and I think we'll start with our evening, and the audience now is going to get introduced to Dr. Nick Canzanello from the Mayo Clinic, Rochester. Nick, thank you very much for joining us.
All right, thank you very much. So I'm going to speak about lumbar spinal stenosis, the exam diagnosis, as well as covering Vertiflex, which is one of the interspinous spacers currently on the market. I think we'll jump right into it. So this is an important topic. This is something that's common to all pain physicians all across the United States. A lot of our elderly folks have this condition. And radiographically, about 47% of patients elderly in the United States over the age of 60 have it, and over 200,000 have neurogenic intermittent claudication, so they're symptomatic from this condition. It's a huge portion of our patient population, and it's the most common reason for spine surgery in patients over 65. It's an expensive condition, over $1.6 billion just for the surgeries alone, and that was back in 2007. So this costs our country a lot of money. A lot of our patients have it, and it's very important to know how to properly evaluate and manage it. All right, so some definitions. So degenerative lumbar spinal stenosis is a radiographic condition. It is where there's diminished space available for neural and vascular elements in the lumbar spine, and that's secondary to degenerative changes within the spinal canal. And it's important to note that it is different and separate from symptomatic lumbar spinal stenosis or neurogenic intermittent claudication, which is the resultant clinical syndrome for this condition. So some classifications that are important to understand. So the majority of these are acquired degenerative, but there are some situations in which it's congenital, and that's mostly due to secondary or to shortened pedicles, and that accounts for about 10 to 15% of patients who present to your clinic with neurogenic intermittent claudication, and this is thought to be idiopathic, but there is a couple of syndromes where it can be more common, such as achondroplasia. In terms of the acquired classification for lumbar spinal stenosis, this is mostly degenerative, although post-traumatic and iatrogenic, such as adjacent segment disease, could be included, as well as space-occupying lesions. There's an anatomic classifications, and this is mainly thinking of the spinal canal as a separate entity from lateral recess or subarticular recess and the neuroforamen. On the right over here, we see that there's different areas of the spinal canal that can be compressed and considered stenotic. The central canal is pretty self-explanatory. The lateral recess is a common point of confusion, and the borders here, the lateral border is the pedicle, the dorsal border is the superior articular process, and the ventral border is the vertebral body. And this is commonly where you would see injury to or compression of the traversing nerve root. And then the neural foramen is another area. And this is most commonly happening at L4-5. Another view, an axial view, shows that that the central canal is next to the lateral recess or the subarticular zone, and then we have the foramen, and this is just the axial view of that. And so that you have to consider potential causes of lumbar spinal stenosis. So the pathophysiology, there's disc degeneration, and that does two things. That increases the load on the posterior aspect of the disc, and that leads to end plate hypertrophy, disc herniation, and bulging, and both of those reduce the space in the central canal and the lateral recess. The second thing that disc degeneration leads to is a loss of disc height. A loss of disc height translates to a loss of neuroforaminal height, and that reduces the space for exiting nerve roots. Loss of disc height also leads to eventual facet arthropathy and facet increased loading, which can lead to hypertrophy, osteophytes, and synovial cysts that encroach upon the central canal, as well as the lateral recess. And you also get segmental height reduction, which allows for ligamentum hypertrophy and bulking, which can also narrow the central canal. In all of these areas, the central canal, the subarticular or lateral recess, and the neuroforamina have less space during lumbar extension and when upright or axial loading, which is why these patients are complaining of symptoms in those positions or while ambulating. So folks that show up with a history of consistent for neurogenic claudication will complain of usually pain, discomfort, or heaviness, weakness, or numbness in the buttocks, thigh, and lower leg, and often also the back. These symptoms are worse by upright exercise or positions, and they're better with lumbar flexion, and that's the classic shopping cart sign where they're stooped over in a lumbar flexed position, as well as sitting, squatting, or laying down. And again, not every patient will come in and complain, well, I have pain, doctor. They may say, I have some just discomfort or heaviness. It may not be described as a frank or simple pain. And often these symptoms are bilateral and symmetric. However, if somebody has more unilateral symptoms, they may have predominantly lateral recess stenosis or foraminal stenosis, and that could lead to more of a radicular or dermatomal pattern of pain. And a lot of these patients have low back pain that is occurring as well, but as best we can tell, this isn't a result of the spinal stenosis, but just a sequelae of the overall degeneration of the spine that's occurring, such as lumbar spondylosis. When you're evaluating these patients, you need to consider some of the mimickers, different musculoskeletal issues such as sacroiliac or bursitis, hip arthritis, potentially insufficiency fractures, different types of neurologic conditions, peripheral neuropathy, as well as plexopathies. And then the most classic one that this can mimic is peripheral arterial disease, and there's a few ways you can tease that out. Cycling, which is something done typically in the lumbar flex position, shouldn't really increase symptoms in patients with lumbar spinal stenosis, but for PAD, for peripheral arterial disease, it may make their symptoms worse. Uphill, walking uphill, you typically are in a more flexed position, and so patients with stenosis may not complain of much symptoms there, but it's worse with patients with peripheral arterial disease due to a higher metabolic demand. And then climbing upstairs, same type of thing, also in a lumbar flex position, minimal pain for people with stenosis. And then standing as well, peripheral arterial disease patients may feel fine standing, but we know with lumbar spinal stenosis, even in a standing or upright position, there's increased axial load and less space for the neurovascular elements. the physical exam for these patients is mostly important to rule out other things. Only 10% I have a positive straight leg for these patients, and you just need to spend a little bit of time checking for vascular disease, getting symmetric and robust pulses, and just making sure that they didn't have any areas of tenderness to palpation that could point to a musculoskeletal etiology. And if the diagnosis is unclear, you can try a stoop test, which is having them provoke their symptoms by walking, or especially if they're in a little bit of a extended position. And then they switch it up and do a more of a flexed or stoop forward and see if if that position of flexion would relieve their symptoms. Switching over to imaging, the best imaging modality would be a spine MRI. These days, the vast majority of folks can get this even with most cardiac pacemakers, spinal cord stimulators. So we highly recommend that, but if not, CT myelography or even just a plain old CT without contrast would be okay. But in general, the correlation between imaging evidence and clinical severity of stenosis is poor. And you need to look at your own MRIs if you're going to be doing any sort of treatment. Another important image to get would be a lumbar flex-X films, so lumbar spine radiographs with flexion and extension, looking for the signs of instability, such as 3 millimeters of a translation on a sagittal view or lateral view, indicative of having some instability in spondylolisthesis, or other indirect signs listed below: big facet effusions, big cysts, interspinous fluid, and these would all be indirect signs of instability. There's a number of ways to radiographically determine the severity, and these slides will be available if you want to look through them, but in the interest of time, I'm going to move through fairly quickly. I think it's important to look at sagittal and axial cuts and consider both of those as important for diagnosis of both central canal lateral recess and foraminal stenosis. And one of the imaging grading systems would use CSF space and foraminal height, and as CSF space gets obliterated in severe spinal stenosis in the central canal, all you're really left is with nerve roots and no CSF surrounding them. And one other thing to mention is that on a sagittal film, when you're looking at the foramen, you're looking at the nerve root, if there's epidural fat around it, and the space for the actual nerve root itself, whether it's not, it could be deformed, and sometimes you'll see in severe stenosis where there's compression or flattening of the nerve root, and that would be more severe foraminal stenosis. There's other grading systems where they just consider it based on percentage compared to adjacent levels. And when we talk about Vertiflex, I'll mention that a little bit in more detail. Just a quick overview, we're going to talk about interspinous spacers, endoscopic decompression, and the mild procedure today, but just know that there's some conservative cares that should be trialed first: medications, epidural injections, and then we move on. And according to the MISC guidelines, we have this nice figure here that kind of shows the invasiveness and duration of effect, and going up, moving along, we're going to get more invasive, but potentially higher risk, weighed with a better, more durable benefit. So Vertiflex, one of the interspinous spacers currently on the market, this is approved to target 1 to 2 adjacent levels from L1 to L5. Generally not feasible at L5-S1, and that's due to a rudimentary spinous process at S1. Now we know some people have arguably a 6th lumbar type vertebrae, and those folks, it may be possible to place these devices if there's a good enough spinous process there, and there's stenosis at that level. It's possible to get a little bit lower on that, depending on how you determine the enumeration. And what the goal of an interspinous spacer is to provide a mechanical block in lumbar extension. So it basically prevents lumbar extension and compression of the neurovascular elements during extension. So we're indirectly decompressing these structures. We're not directly decompressing. We're not removing hypertrophy ligamentum flavum. We're not removing hypertrophy facet joints. We're not doing any of that. We're just doing a mechanical block to indirectly decompress and prevent symptoms. These products entered this U.S. market in 2005. X-Stop was one of the early ones that was available from 2005 to 2015, and then was taken off the market in 2015 due to having a high side effect profile or complication rate. These interspinous spacers, they've reduced complication rate now compared to decompressive laminectomy, but potentially a higher rate of reoperation depending on the study you're looking at. Indications for Vertiflex, basically having what we described as a classic presentation of lumbar spinal stenosis, but having relief in flexion position. And that's really a key component here, is that if we keep them in a relatively flexed position or do a mechanical block to the extension, that these patients will have relief. If they have pain that continues through lumbar flexion, sitting in a flex position, then they are not candidates for the Vertiflex procedure. Other indications required would be a moderate lumbar spinal stenosis, and that according to the Vertiflex folks is a 25 to 50% reduction in the space, and that could be in the central canal or the lateral recess, subarticular recess, or neuroforamen, and that's compared to the adjacent levels. So that was a little bit different than what we reviewed earlier, showing that we're looking at stenosis based on CSF obliteration, or a mid-sagittal diameter of the spinal canal. That we're not talking about millimeters anymore. We're talking about just a reduction in space for the neurovascular elements compared to adjacent levels. So I think it's pretty easy to remember 25 to 50%. If you're going to use this criteria, it's easy to think, well, then this is moderate, so less than 25 is mild, greater than 50 is severe. Those are not candidates for the Vertiflex procedure, and most of the time, unless you're going off label. Let's see. So we also want them to have associated signs and symptoms, including, having some disability, impaired physical function, but we also want them to, still be up and walking and be able to move around. And our goal is just to help them do that better. Some contraindications that are important to review are lumbar spondylolisthesis greater than grade 1. So that's a 25% or less translation of one vertebrae on top of the other. Any fracture or ankylosis, scoliosis, so Cobb angle at 10 degrees. That doesn't mean that they can't have thoracic kyphosis or a higher lumbar, or a thoracolumbar curve that starts around L1 and you're treating L4-5. That would be irrelevant. We're looking at just the amount of curvature, rotary or otherwise, at the treatment level. So we want to make sure that this two spinous process that you're putting this device between are lined up fairly symmetrically, so that there's at a minimized chance of the device migrating or becoming dislodged. Osteoporosis, obtaining DEXA scan is an important screening criteria. And then pretty obvious other contraindications here. I think it's important to discuss the risk of spinous process fracture. This is fairly high, and up to 12.1% in one trial. They've done some things to mitigate that risk and reduce it, and that's mostly to do with correct size device size measurement. So when you're doing this procedure, you're measuring. There's a measuring tool, interspinous gauge, and that gives you a millimeters of what size device you should be implanting. And Just making sure that you're not oversizing is important to reduce the fracture risk, as well as putting this device deeper and adjacent to the spinal laminar junction rather than more dorsal. And if you put this thing more shallow, then there's a risk of increased risk of fracture. If you have thin spinous processes that are less than 2 centimeters tall, or kissing spinous processes, so if there is very little inner space in between the 2 spinous processes that you're targeting, generally due to severe degenerative disc disease with loss of disc height, then you might be kind of shoving this device in between those spinous process at kind of high pressure, and so you may have an increased risk of spinous process fracture as well. And an obvious one would be osteoporosis. So just a quick review of the evidence here. This was the initial study, and this was Techmeister et al. And he looked at 316 patients. They got 60% improvement for leg pain, 50% for back pain. And then the responder rate based on their clinical, their MCID or clinical success criteria was 75 for leg and 67 for back. And generally, these patients were satisfied. There was another, a later trial. It was a non-inferiority trial when this device entered the market. It was X-Stop versus Superion, a Vertiflex. And so they were looking to establish that Vertiflex or Superion was not inferior to X-Stop. So they split this group up of 391 patients. 190 got Superion, 201 got X-Stop. They did pretty similar, very slight differences, but not statistically significant. And the Superion group, leg pain was 70% improvement, back pain 65, pretty similar to what we just looked at before. And clinical success criteria, 76% for the back pain, MCID, the leg pain, and then 67, a little bit lower for the back pain, and then the ODI, the Osteoarthritis Disability Index, 63%. The last study I'll review here is Nunley et al. And this is 190 patients. This was a 5-year durability study. So they took the same cohort of patients from the last study I just presented and monitored them for 5 years. They had 88 of the original 190 that completed the 5-year outcome assessment. And the percentages of patients who met clinical success criteria was, again, 65 for back, 80 for leg. And then these were the Zurich claudication questionnaire, symptoms, physical function, and these patients did quite well, and 75% of them didn't need an additional surgery at the treated level. So they didn't get a laminectomy, they didn't get additional, spinal cord stimulator or other treatment like that. So I think one of the Vertiflex groups, our rep talks about, they advertise that they get about, if you look at all these numbers, they're about 60% or so, 65% for the back pain, in the 70s for the leg pain, and then in the 80s for opioid reduction and 90s for patient satisfaction. So that's how they kind of advertise themselves, as they get pretty good relief for back, and for back, but a little bit better for the leg pain. And overall, these patients are mostly satisfied. And just looking at a quick film of one of ours that we did, and this, you can see the device on a lateral image here. You'll notice this patient did have probably borderline grade 1, almost grade 2 anterolisthesis. And you see the device here on an AP sitting in between the spinous processes at 4-5 here. And then on the right side of the image here, we show, this is a little model taken from the Vertiflex website, showing that there's a little bit of increase of the neuroforaminal height here. And that's it. I think I'm on time here.
All right, Nick, thank you very much for your 2 excellent presentations, well, in a row. So really appreciate it. I think there are already some questions, I think in the chat box, but may also in the Q&A area. Feel free to answer them if you want to. And I think we'll move to the next presentation. And on my schedule, this is Dr. Maroney. And Dr. Maroney is from the University of Florida, and he will talk about what we call the mild procedure, that's standing for minimally invasive lumbar decompression. All right, and there he is. Matt, thank you very much for joining us.
Good afternoon, everybody. Can you hear me, Dr.?
Yeah.
Perfect. Yeah, my name is Dr. Maroney. I'm one of the pain professors at University of Florida, discussing the mild procedure. So quick, but obviously similar to interspinal spacer, we're focusing on central canal stenosis, specifically in this case, due to ligamentum flavum hypertrophy, specifically greater than 2.5 millimeters. It can press this view. Difference between this and that's must have or a significant contributor has to be due to the ligament, which is not totally the case with the interspinal spacer. I won't review original clavicle lines as that was previously done excellently. So that was the indications. Contraindications, it's a little bit different, that you cannot have a laminectomy at the level that you're targeting. I think from an insurance standpoint, you can't have a surgery at in the last year. Similar to this, you want more than 2 or beyond spondylolisthesis, though that consider that a relative contraindication. Otherwise, you can't be anticoagulated, can't be affected. From a shingle standpoint, that's a relative contraindication. If you think that you can get your equipment in there, you can keep doing it, though you may have to exert quite a bit of force, and there may be concerns that you could fracture the lamina, and you wouldn't want to do this if there was significant instability. Here's a similar MRI showing significant ligamentum flavum hypertrophy. So advantages, similar to the spacer, from an anesthesia standpoint, you do not need general anesthesia. I've done this specifically under complete local. The only reason I did that, though, is the patient was very old and very sick, and that was kind of a negotiation with the anesthesiology team. We used quite a bit of local, and the patient actually did very well. Compared to a spacer, an advantage would be that we are not implanting anything, so very low infection risk, and because you're not worried about something being dislodged, there's minimal post-op restrictions. Disadvantages, similar to other pain procedures. I mean, it would be off-label to pursue this if they were severely stenotic, though obviously some patients may not have any other choice, so it could still be a consideration. And maybe beyond other procedures, there is quite a bit of fluoro or radiation exposure to the patient and also to the proceduralist or the surgeon. Safety standpoints, statistically as safe as an epidural steroid injection. Though I do think it's important to kind of point out that you are not doing an epidural steroid injection. You can get pretty aggressive if you want to, and you obviously need to consent the patient for, you are doing a spine surgery. There are risks involved with that. I think that it is a very safe procedure. I think the equipment is made very, very safely, though, some other things could go wrong, though I think the chances of that are pretty low. During the MIDAS study, one of the main studies, it showed that out of 150 people with the mild procedure, 1 person bled somewhat. This is procedural hemorrhage. I don't think that they died. And another patient had pain, which is not surprising. So very safe. So comparing that to epidural steroid injections, pretty much identical statistics from a risk standpoint. I think it's always important to kind of consider any procedure you're doing, what's the level of data. So there is level 1 randomized controls trials in regards to this. Specifically, it has been shown to improve patients' pain and function over 5 years, and it's very safe. So from a reasonable standpoint, it's not, there's a lot of data behind it. It's very safe, it's effective with the appropriate patient population. So the motion study is one of the studies that are significantly referenced with this year. They had really good 1-year data, which showed that compared to conservative management, patients were, from a percent improvement standpoint, 250% better at 6 months and 1 year compared to just conservative management. And these patients are I think one thing it's important to point out is that generally most people think that mild is probably appropriate if your main problem is central canal stenosis due to ligamentum hypertrophy. Though the study did show that patients that had maybe lateral or lateral recess stenosis did benefit from this. So you don't have to rule them out, though I would argue that you really have to be probably pretty comfortable with technique to access these areas, trying to get to address the medial and lateral aspects of the interlaminar window, to even consider pursuing these in patients that have issues that are a little bit more lateral. Though the study did show that it could affect those improve those patients. Obviously, it will not help if they have majority of just foraminal issues. You're not going to get that lateral. From a result standpoint, the patients that received mild had only a 5.8% repeated lumbar spine intervention versus 6% just conservative management. So again, that speaks for itself to some degree. And very recently, our ASPN released a MIST, which is minimally invasive lumbar spinal stenosis treatment guidance, which pretty much is an algorithm. This was released last month about when to consider these things. Kind of the long story short, if they call it a PILD, so percutaneous lumbar decompression. If you have lumbar stenosis to ligament hypertrophy, then you should consider these at M2 to L5S1. Obviously, L5S1, you frequently can't get a spacer in there, so that is something unique, I would say, compared to spacers as well. People these things too is, should they do a spacer versus this? Just briefly, the procedure is placing a portal, accessing your interlaminar window, using a bone rongeur, and then a tissue sculptor to the ligament. The idea is that you're going to be trying to target this the ligament. You have lamina here, and you'll be using the bone rongeur to kind of access or gain access to this area, so that you can remove some ligament. Just briefly, frequently an epidurogram is used to identify or delineate the epidural space, though frequently you can't get it there. So there has been studies specifically addressing this. Do you need an epidurogram or not? And there was one retrospective review of almost 150 patients that had no adverse outcomes if they were treated without the epidurogram. Though you need to, obviously, you're generally going to be using the VILL, the ventral interlaminar line, as your line, your safety line, so you don't go past that. So just briefly, you're going to access the interlaminar window with a trocar, diamond tipped. You're going to place the bone rongeur, which will generally open up the window for your tissue sculptor. Again, trying not to penetrate the VILL, and your goal is generally to get 2 cc's of ligament, which is like 2 mLs. I wouldn't start, these are different types of situations. You may consider this, though they're a bit harder. You can look at that later. And from a post-op standpoint, frequently people are doing pretty well the day after, though from my experience, patients can have some oscillating pain over the next few weeks, and that makes sense as inflammation, swelling, bleeding, clots all kind of go away. So I would let the patients know that you may be a little bit more sore after a few days, and that should improve over 6 weeks, and just wait and see, and don't get upset if you have a few days of soreness. I think that puts me at about 10 minutes.
Right. Matthew, thank you very much for your great presentation and also staying on time. I know that's important, and I know you have a lot of slides, data, and images to present, and I think we can move to the next presenter. This is my colleague, Dr. Sanjeev Kumar from the University of Florida. And I think he will talk about, I think he is coming on, lumbar spinal stenosis, endoscopic interventions to relieve symptoms and pain for our patients. Sanjeev, thank you very much.
All right.
And I think we'll start sharing the screen.
Yes. Can you see my screen?
Unfortunately, not yet.
Okay, let me start doing that something.
Right, here we go. Yeah. We see slides.
Okay. Right, let's see. Okay.
We can go to the presentation mode. See if that helps.
Yes, can you see my slides?
Yeah, perfect.
Thank you. Well, good
All
evening.
right, this is the first slide. Thank you.
Yes, thank you. And my name is Sanjeev Kumar. I'm at University of Florida, like with Renee and Matt and Amir coming on board. We have great colleagues at University of Florida, and thank you for joining. So this talk is about endoscopic spine surgeries. The term is full endoscopic spine surgery now because we can achieve almost everything with an endoscope that a traditional spine surgery can do. So that's why the name has changed to full endoscopic spine surgery. I have no disclosures. I'm not a consultant. I don't get paid for lectures. I'm not affiliated with any company or device maker. So endoscopy is the least invasive approach and has the best visualization of spine pathology. It's like an eye inside the spine. So on the first left side of the screen, you can see an open surgery being done. This was traditionally how the spine surgery used to be done in the last century. And from the eye level, you have to cut down the skin, the muscles, the fascia, the bone to get access to the spinal canal. And you have to do pretty wide cutting and decompression to achieve to get access to the spinal pathology. Then microscope came in the 70s. It was developed in the United States, and more research went into it. And by the late half of the last century, this microscope was the gold standard. Endoscope came also similar to microscope, but the technology advanced quite rapidly in the late 90s and early 2000s. And then you can actually put the scope inside the spine, and it has a light source, a camera, and a working channel, and irrigation channel. So you have great access to the spinal canal. You can visualize everything, and the irrigation keeps your field clear. And you have a high definition modified, magnified 20 times. So you can see the pathology really nice and be very close to the pathology. That's the advantage of endoscopy. So brief history, the early half of last century, laminectomy and decompression were common. But then the surgeries were more traumatic. So it was the moniker that most spine surgeries end up having more complication than actually giving benefit. So that was, people are scared of spine surgeries. So cutting to the other part of the slide, in the late 90s and early 2000s, the big advancement in spine endoscopy came. As you know, endoscopy started in 1975. Hijikata in Japan, he published his findings in Oxford Journal. He couldn't get credit for that. But by 1996, Tony Young in 97 and Hal Matthews in 96, they refined and modified the instruments so they can have a transfemoral approach to spine endoscopy and have a continuous irrigation. Hoogland in Germany started outside-in approach where he can start from outside the foramen. You can drill the facet and drill the pedicle. So even with foraminal stenosis, you can still put the endoscope inside the foramen. And then the game changer was Sebastian Rutten. Dr. Rutten, he used orthopedic shavers, drills, and burrs. And then also holmium laser was used in the late 90s and early 2000s because that allowed people to cut in underwater. So that was a game changer. Then again, Gun Choi from South Korea, he popularized that and trained many surgeons, and they went around the world and started this spine endoscopy business. So the other big advancement in spine endoscopy was like around 2011, 2012, where bipolar radiofrequency electrocautery was patented and introduced. So this replaced the laser, and this again is a great advancement in spine surgery because the electricity travels like a millimeter further than the heat travels. So the leg will jump before the heat can damage the nerve. So it has a steep learning curve. And why is it difficult even for experienced spine surgeon? Because there is no way to manually touch, feel, apply pressure, or palpate bones or soft tissues. Even a slight deviation of scope position can become very confusing on the screen. And the scope tower, unless you know anatomy very well, so it needs a lot of practice. The fluoroscopy is essential ingredient, especially for initial guidance, but also for maintaining the depth and medial lateral cephalad quadrate orientation. So even if you don't achieve anything from learning in spine endoscopy, you can become a better pain physician because you know anatomy, floor anatomy very well, because you won't be scared that my needle is going too medial or too anterior, because you can think in 3 dimensions where the needle is in relation to the dura or the nerve. It's not easy to maintain the working tube or scope position using one hand for a prolonged period while wielding instrument for another. And also the joystick move of scope and burr moving together, take down lamina, the facet is easier to look and watch, but in reality it's quite tough. So you have to have a lot of practice for that. So when we try to teach surgeons, and they have a hard time trying to adapt to this skill sets, but eventually the surgeons who do adapt, they really are thrilled with using the endoscope because it's much better compared to their traditional surgeries. So of course, this topic is meant for pain fellows and practicing pain physicians. So what are the steps that you need to take if you want to start a spine endoscopy in an institution? So you have to reach out to neurosurgeon and ortho spine because they are likely the ones who are doing spine surgery in institutions. So you have to reach out to them. And first, of course, you have to break the ice. If they are not doing it, then you are trying to learn something and bring something new to them. So some of the older surgeons are difficult to, they don't want to learn new things. So it might be worth your time and effort to learn it and try to bring this to an institution. You have to shadow, mentor, and observe live surgeries. It's a very steep learning curve. So it looks easier than it actually is. And you have to attend cadaver workshop like a NAS, ASIP, or ASRA. You have to get credential from an institution as well as malpractice insurance carrier. And then you should start with rhizotomy because that is outside the canal. It's like similar to needle radiofrequency ablation. So the target is same, the junction of the superior articular process and the transverse process, but what you get is you get used to holding the scope and using the instruments. That makes you a better physician who can wield those instruments inside the canal. So starting out for the spine would be the transfemoral endoscopic surgeries for foraminal herniation because it's right there in the foramen. If you put a scope down, you'll be looking straight at the herniation. Then, of course, advancing to paracentral herniation, then central herniation. And for the interlaminar approach, L5S1 disc herniation, you have to do at least 10 of those, because it's usually a wide interlaminar window. And then once you get more experience, then you can go to higher level because frequently it will involve bone resection. So you have to use burrs and drills and your keratine to cut bone. And then once you get comfortable with those things, those kind of surgeries, then you can start approaching the stenosis cases like the foraminal stenosis, lateral recess stenosis, and central canal stenosis in that order. And then, of course, you can progress to thoracic spine and cervical spine once you get comfortable with lumbar spine. So all these slides and pictures and videos are from our patient. They have given permission for sharing their clinical data for this presentation. So this is a starting out case. This is again, one of my fellows did it all by himself. And this is the right, you can see on the upper left corner, the right paracentral disc herniation. This is the pre-op image, axial cut and sagittal image. And then again, after post-op, the image is clean. You barely see the entrance of the scope. There is no scar tissue and the pathology is taken care of. So it's a clean surgery. Again, this is the X-ray image, fluoroscopic view, how the scope, the needle went in first, then the dilator goes in. And then the working tube goes in. This is a bipolar trigger flex, and this is another instrument. And this is the view from the scope for the same case. I'm going fast because there's a lot of slides to cover. So this is an interlaminar case. This is a right L5S1 paracentral disc herniation, large disc, impacting the transiting S1 and S2 nerve roots in the dura. You can see the sagittal cut here. It's pretty big disc herniation. And this is again after surgery. The pathology is taken care of. The disc material has been removed. The extruded disc material has been removed, and a sealing effect has been taken care of because of the bipolar has sealed that annulus. So it's not irritating any nerve roots. And this is again the sagittal view of this post-op surgery. This is how the scope was placed in fluoroscopy view, the same approach. You can see the endoscope going into the recess zone. And this is the lateral view. So this is without taking any bone out, without causing any collateral damage, the pathology was taken care of. So we also do take majority of our surgeries, at least at our institution, because they're referred from our surgeons, is they already had prior back surgery, prior spine surgeries. And a lot of them have scar tissues engulfing the nerve roots, and they have dysfunction, nerve dysfunction and pain and disability from that. And we do frequently go in and clean out the scar tissue from previous surgeries. So as you can see, this is the previous hemilaminectomy that has been done. This is the fluoroscopy view. This lamina, L4 and L5 lamina has been cut. The endoscope is going in there on the left side, and this is the instrument that is taking care of all the scar that surrounds the nerve root. So from the scope view, it's like peeling in the onion. The scar tissue around the nerve looks like white, chalky stuff. Is dense, white, chalky stuff, and we have to slowly be very careful, but slowly we can keep peeling off. And with continuous irrigation of the bipolar and our other fine instruments, we can actually are able to clean and free the nerve tissue of the surrounding scar. And this is how the nerve looks like once it's cleaned out from the scar tissue. So there's a hidden zone we call the hidden zone of McNabb. Was a neurosurgeon. He described the hidden zone. It's very tough to reach the hidden zone from a microscope, and also with an open approach as well. It's tough because you have to lift up the entire spinal cord and nerve root. But an endoscope can easily, we can get access to the hidden zone by lifting the dura and the nerve root. And we can see if there's any pathology hiding. A lot of that times, the residual disc material or some cyst or some other like an osteophyte usually sometimes is hiding in this, which can cause persistent symptoms out of spine surgery. So it's very useful to lift up the nerve root and the dura to look underneath that and get access to the hidden zone to make sure that there's no pathology hiding there. So we also take care of a lot of chronic old scarred herniations. So this is another case where it's a chronic L5S1 disc herniation. We're starting out. We keep exposing. This is the flavum ligament. This is pretty thick because old herniations, so the flavum gets quite thick. And you can start seeing the entrance to the epidural space. The flavum is being cut. And you have to keep clearing thick flavum and keep exposing the dura. The dura is seen here. The blood vessels on the dura are seen. And so once you clear the lateral recess zone, that means anything that is putting pressure on the traversing S1 nerve root will be cleared up from compression, which can include the descending lamina, the sipidarticular process, the ascending lamina, so all, and the thick flavum, of course. So any structure that is mechanically causing possible irritation to S1 root can be taken care of. So we clear up the lateral recess, so that prevents any future irritation of the S1 root. So when we expose the axilla, this old chronic disc herniation, this is the S1 nerve root. See how it looks red and inflamed. And there's a lot of adipose tissue, even though the patient was quite skinny, but see the adipose tissue is there to form a cushion between the nerve root and the structure that were compressing the root. So this was quite red and inflamed because it was an old chronic disc herniation. This patient had a herniated disc when he was just 7 or 8. So he had waited till he became an adult to see me. So after you keep clearing the axilla, you start relieving pressure on the inflamed S1 nerve root. You can see the structures are slowly being removed. And in front of your own eyes, the red inflamed nerve actually looks less red now. You can see that it looks more pink. So that happens pretty often. It's amazing how to see the transition under our eyes. And then this is the rent, in the annulus where the disc herniation, old disc herniation came off, where we cleaned it now, so you can see the rent. You can see this is old chronic disc herniation. They came out from this. From this area. Let me just go back to my presenter's view. Okay. So okay. So now you can see this is a video of how the nerve root looks when you decompress. This is again under irrigation. So the dura is moving nicely, the S1 root is moving nicely, so there is no pressure on that. Once you see that the nerve is free of any compression, any pressure, you can rotate the scope, look around the corners. look underneath, look over the dura, look on the other side. And that's how you rotate the scope, and you can see there's no pressure. And of course, you have to make sure there's no bleeders as well. So once you feel that you've done your job, I mean, the nerve is free of compression, that means your job is done. So that was a picture of inflamed nerve root. This is a picture of a normal dura on S1 root, and this is again the axilla. You can see the difference between this picture and the previous picture. That's how nerve root old herniations can have chronic irritation on nerve roots, and patient can have chronic pain and suffering. That was an inflamed nerve, and this is looks like a pretty normal nerve root. So this is how we get access. What we do is to protect the nerve root and the dura by rotating our working tube. And you can see there's a big rent in the annulus, and we rotate our working tube to get access to this rent. And you see how we can we're going to rotate and get our instruments inside. This is again the nerve root, and I'm going to forward it a little bit more. You can see our forceps going in and taking out any loose material inside the disc. And then again, so again, these are some of these slides from our patient, large disc herniation. This patient had a common sheath, L5 and S1 nerve root had a common sheath. This patient was seen by a neurosurgeon. They're planning, this patient had more left-sided symptoms. They're planning a left-sided microscopic surgery. They still saw me, and I discovered something on the MRI which everybody missed. It was a common sheath, nerve sheath of L5 and S1. So I said, a left-sided approach might be more dangerous. So why don't we try an interlaminar approach on the right side? And this is how we did. And this looks like clean surgery again. No evidence of scar, surgical scar. The pathology is out. And even the modic changes, you can see the modic changes there at L5S1 on the axial cut. That changes also get resolved with endoscopic surgery. So this modic change for which the intracept procedure is used, there is no need for that because now the surgery has taken care of the modic changes as well. So this is again a high definition image of the same thing. This is the L5 and S1 roots sharing a common nerve sheath, the axial cut and the sagittal cut. Okay. And again, we also take care of every pathology in the spine, large L4-5 disc herniation with downward migration causing severe central spinal stenosis. This is the pre-op image. And then this is the post-op image for the same patient that was surgically taken care of by the endoscope. And we take care of a lot of older patient, and we named a MRI finding in spine called gated sign. This was because it was discovered at University of Florida. So we named it because there's perineal edema on the nerve roots. And once we do the decompression surgery, these perineal edema disappear. So the gated sign disappears after our surgeries. And this again, as we go higher up, you can see the L4-5 central canal lateral stenosis. We can do a full endoscopic decompression. So what we do is we go over the top. We start from one side and we can go on the other side. We just turned, you can see the interspinous ligament is there, the pink thing there, and this is the dura, and we can put our carisons right underneath that, and we're going over the top on the other side to decompress the other side as well. So we can clean out both sides. You can see the adipose tissue there over the dura, and the ligament has been cleaned out nicely. And once we clean out everything, it starts to move nicely. Everything starts to move better. There's more pulsation of the dura and the nerve roots. So again, as you go higher, you have to do more bone resection. So when you start out, thick flavum and the epidural fat is seen, and need a quite bit of bone resection. This is all the edges of the lamina that's been resected on this level. And so all the instruments we have the same, all spine surgery instruments are just a smaller version that we use through the endoscope. All the various drills, birds, the carisons, the rongers, everything is there, the same instruments. And this is how we clean up the lateral recess. See how lateral recess looks nice and clean there. And so one of the things that we have to be careful when we deal with severe stenosis is a lot of adhesions because of chronic inflammation. The ligament of flavum can be adhered to the dura, and this forms like folds in the dura. So you have to be very careful. This is why sometimes it's not advisable to do neuroaxial procedure. Like when you're putting a spinal needle, you can actually cause more trauma to the roots because there's no space. All the nerve roots are kind of clumped inside the dura in this place. So it's not advisable to do any neuroaxial procedure in severe stenosis cases. This is how it looks like. This is how the dura is folded up and is adhered to the flavum ligament. So so again, these are dural folds. This can be really very disastrous if you're not careful. See how the thick flavum is there. So everything is like in a hard shell, and the whole dura can be folded on itself, and the nerve roots can be inside. So you have to be very, very careful. Again, you can easily cause injury to the dura if you're not careful. So this is how. But once we start decompressing, you can see everything gets better. So these folds disappear once we do proper decompression, and then the dura has more breathing space and it starts to move freely. So we also take care of a lot of times when we see epidural lipomatosis, there's adipose tissue, but see the vessels that are crisscrossing, they're likely bringing the adipose tissue. So you have to be careful because they're likely be bleeders. You expect bleeders there. So it can get bloody sometimes when you deal with that, and the blood can appear. And so this keeps us in practice really with potential epidural hematoma. So we take it as an opportunity to learn how to take care of epidural hematoma. So of all these hundreds and hundreds of surgeries I've done, we never had a complication of epidural hematoma, which is good. So we have also take care of, we do osteotomies and vertebral artery dissection as well. So sometimes you see, even in spite of all these multiple surgeries, you still see patient is in pain. A lot of times there's a pseudo joint between the sacral ala and the L5 transverse process. And sometimes if you can spot it in this area, so we put our instruments, we just drill that out. And I'm going to go fast because we are running out of time. So we identify the pseudo joint, and then we can drill and kerrison this. And this is another picture, same thing. Through this, we can also access lateral disc herniation as well. So this is the pseudo joint there. This is pre-op image. This is post-opsy. This has been drilled out. And sometimes because of this, the spine also straightens up a little bit as well if there is some scoliosis in that area. So we do know how to take care of complications. A lot of times, people are, oh, do you know how to? Yes, we do. We take care of dural lengths. Number one, it's very rare to have dural length with endoscopic surgery because the instruments are small. But if it does happen, we have the Duragen, we have onlay and inlay graft, we have fibrin glue, we have surgical tacking. We can also suture with 6-Proline if needed. We teach this in our cadaver labs. We do simulate epidural hematoma, so we are always prepared for it. We can deal with either flow seal or putting fibrin, or we can even leave a drain in connected to suction, and we can monitor the output. We've also offered, we work closely with our neurosurgeons, and we have offered our services of epidural hematoma drainage via endoscopic approach to them. If they ever are in need of us, they can contact us. So some of the benefits of endoscopic spine over traditional surgeries are we preserve bones, muscles, and soft tissues. And the spinal architecture is almost unchanged after spine endoscopy. There is minimal scar tissue recovery is very quick. Most of surgeries are done outpatient, and some can be done under local and MAC. And it doesn't burn any bridges for traditional surgery. So even after you have done endoscopic, you want to have bigger surgery, say you haven't achieved the desired outcome, or the spine becomes unstable going in the future, so they can always have a bigger fusion surgery. So with this surgery, even old herniations and adhesions and scar tissue around them can be better managed. And the chance of duality is actually much less in spine endoscopy because when the irrigation fluid goes in, it pushes the dura down. So there's more space between instruments and dura. So the dogma for all spine surgeries are bad doesn't hold true with endoscopy. So earlier intervention prevents chronic pain and degeneration stenosis in the future. Of course, there is some contraindication. It's not for unstable spine. If the person has unstable spondy, please send them to surgeons for fusion. Or if there's a complex scoliosis, of course, it's also not a good choice for that. So there's the biportal approach now, and there's EndoLift, which is endoscopic assisted lumbar fusion is here, so which has expanded the horizons for spine endoscopy. So a lot of times we feel like the spinal cord stimulator can give relief to pain, and a lot of times the companies and the reps they push for stimulators, but pain relief can be achieved, but recovery of nerve function will not be achieved by putting a stimulator. And also, the stimulator cannot relieve neurogenic claudication, which comes from stenosis. So but we've seen that once we decompress the spinal nerve root from pressure, the function recovers pretty quickly. And we have seen like foot drops recovering in the patients who come in a wheelchair. And can I get trained in spine endoscopic spine surgery? Yes, we have a fellowship at University of Florida. We done by myself and my colleagues at University of Florida. This is the first in the country endoscopic spine fellowship. It started at UF, and it's an extra year with certification. Pain medicine physician apply. You also get a lot of applications from neurosurgery and ortho spine as well. We do look for applicants who have good training in interpreting spine images like MRIs and CTs to get a 3D perspective, and they can understand spine architecture because we do create osteotomies, so they know they should be aware of architecture integrated to the spine. So we have many first, a lot of things have been done at UF. We have reported successful case series of facet decompression. We have reviewed pain outcomes after endoscopic surgery. We have done resection of ossified ligamentum flavum. We have reported first case series of Bertolotti pseudojoint resection by a pain physician. And
Thank you very much, Sanjeev, for the excellent presentation and the videos. They're very graphic to describe, what we see, what we're looking at. So we highly appreciate that. And I think it was very good for the audience. We can move along to the last presenter, and this is Dr. Amir Jafari from the University of Florida, and he will talk about SI joint fusion.
I'm sharing my screen. Hello. Please let me know if
Looks good.
all right. My name is Dr. Jafari. I'm one of the assistant professors at University of Florida, and I'll be presenting SI joint fusion. SI joint is one of the big joints in the body. There are two of them, obviously, one on each side. And this joint is a synovial joint between the sacrum and the ilium bone. The joint is surrounded by very strong ligamentous structure, both anteriorly and posteriorly. And one of the big ligaments is called the iliolumbar ligament, which can be seen on MRIs, actually on the axial view, being attached between the transverse process and the ilium. Now, this joint connects the upper and the lower body. It's stabilized via interlocking mechanism between the ilium and the sacroiliac, and also, it has multiple different motions: gliding motion, rotation motion, tilting, and translation. This is definitely SI joint is a common source of pain in patients with lower back pain. Approximately 15 to 30% of patients that complain of non-radicular lower back pain usually have a SI joint dysfunction, which is the main source of their pain. This is what the SI joint looks like. You see the ilium here, the sacrum, and usually, this is a normal anatomy, but if you look at a patient who has a lot of arthritic changes in the SI joint, these lines don't look sharp, and it's not a straight line. It's very bumpy, and for example, on an X-ray of the pelvis, you would see whitening of the edges, like you would see in a severe arthritic knee. You look at them enough, you'll start recognizing, which patients have pathology in that area. Now, as you can see posteriorly, the joint has a lot of ligaments that is protecting it. So doing any kind of procedure here, you're going to feel some good resistance getting to the joint line itself. It's not just muscles and tissues and fat you're going through, but it's actually ligaments you're tearing through as well. Now, what are some treatment options for patients with SI joint pain? Definitely, you start with physical therapy, straightening, pelvic floor exercises, medication management. This is inflammatory type of pain. So anti-inflammatory NSAIDs, Mobic, medications, opiate management. Obviously radiofrequency ablation can be done. Steroid injections on the nerves can be done. But at some point, all these procedures, the return diminishes over time. And that's where the next option of SI joint fusion comes in. Now, there are various different approaches in the SI joint fusion, and the ones that we're familiar with in the world of pain, interventional pain, is the posterior approach, and most recently, the lateral approach. Now, what are some indications for SI joint fusion? Patients that have chronic SI joint pain that have failed the conservative treatment. You want to have 3 or more positive physical exam findings, like the provocative tests that are done. You want to have done the steroid injections, and the patients get at least 75% or more pain relief on these steroid injections, but they don't last, more than 3 months. Because if it does last more than 3 months, then you can just repeat the steroid injection unless the patient is not interested. Now, let's say you do the steroid injections and they last 2 weeks. They work great, but they last 2 weeks. And you want to prove that the pain is coming from SI joint, and the pain relief is not from a systemic absorption of the steroids. So what do? The way we treat this is we do a diagnostic block where I usually inject no more than 2 cc's of bupivacaine, 0.5 bupivacaine. This way, if you use a larger volume, the medication can leak out and numb other areas, nerves, and the sensitivity of it goes away. So 2 cc, lower volume, just pure bupivacaine, so you don't involve the systemic absorption of steroids. And this will be a great diagnostic technique, proving that that is where the pain is coming from. Some of the physical exam findings, patient comes in and they use their thumb and they point with their thumb at the SI joint, at the PSIS, usually medial or lateral over it. It's very hard for patients to point exactly where the pain is coming from, because most of these patients also have some component of lumbar spine pathology as well. When you press on the sacroiliac joint around the PSIS, you can easily reproduce the pain. Sometimes they jump off the table. Now, some of the provocative tests that most people are very familiar with are the flexion, abduction, external rotation exam, the compression test, the thigh thrust, distraction, and the Gainsleyan maneuver test. You need to have, if you have 3 or more positive tests, you can have high confidence that the SI joint is what's actually producing this patient's pain. Due to the lack of time, I'm not going to go over these physical exams, but they're pretty straightforward if you watch some YouTube videos on it. Now, how does a lumbar fusion affect the SI joint? 20 to 30% of patients who have back surgery end up getting the diagnosis of failed back surgery syndrome. They come back, their back hurts again, same worse pain, radicular pain, or axial pain. Now, SI joint pain is a big contributing factor. I think it's 30 to 40% of failed back surgery syndrome, and it's missed a lot of times. And when a patient gets a fusion in the lower lumbar spine, that fusion actually can increase the motion and the stress in the SI joint. There was a study that they looked at the models of spine and pelvis, and they simulated the motion. And the more fusion was added to the spine, the higher the level of stress and motion was caused in the sacroiliac joint. Like a L4, L5 fusion, compared to L4 to S1 fusion, the L4 S1 created a much more, a greater amount of motion in the SI joint. So fusion definitely affects the sacroiliac joint. The more stress, the more motion, the more arthritic changes. And the average just was higher the larger the fusion was. Now, the incidence of, there was another study that looked at patients that received a lumbar fusion 5 years out, and 75% of them had severe degeneration on the CT imaging. And this shows that this definitely affects these patients. And you should add that to your diagnosis and investigate when you see people who come in after fusion. Now, in reverse, SI fusion, which definitely reduces the motion in all kinds of planes of motion of the SI joint, actually didn't cause that much motion in the hip or the lumbar spine. I think it caused about 5% motion, which was much, much less than what the lumbar fusion would do to the SI joint. Now, this is an image of a SI joint. Looking at it from posterior to anterior, you could see that the joint goes from medial to lateral. And then looking at the coronal view, you see that the cephalad portion of it is much bigger. And usually when the injections are done, they're done in the bottom of the joint. I personally focus on, when I do my SI joint injection, I try to usually prepare for a possible fusion in the future. So the way I do my injection is I place the needle similarly the way I would do a posterior fusion, just to get an idea of how open this joint space is. If I decide to do a fusion, am I going to be able to get in there at all anyways? Now, these are the different approaches. There's the posterior approach, the lateral transiliac approach, and the posterior lateral transiliac approach. The posterior approach should actually be going through here. This arrow is a little bit off, but now this, most of us are familiar with the posterior approach. I think it's much more, it's less risky, it's simpler to do, and what it is basically a bone allograft filled with demineralized bone that fills up these holes. And once this device is placed inside the SI joint using a dilator, remember, you're going through all those ligaments to get into this joint. So there's going to be some resistance. And once this device gets in there, the bone will basically fuse both sides. This is a picture of the lateral approach. The lateral approach, the working tube gets placed laterally with a lateral image. Usually between 2 to 3 screws are placed. And that is obviously, you know, it's a much more stronger fusion. It doesn't cause the distraction. Now, in this approach, you worry about actually hitting the superior gluteal artery, which is a very big artery. And if it's hit, it can cause severe bleeding. And, you know, one of the things we're considering is doing an ultrasound of these patients preoperatively to see if we can mark the location of the artery. But based on the way the procedure is taught, you know, they have a safety zone that, you know, most people follow. And you're supposed to basically be in a safe zone in the middle and miss these arteries. But I'm sure a lot of people have anatomical variations, so you cannot 100% trust that method. Now, what are some post-op cares? These patients, posterior approach, you're putting an implant in a patient, you have to worry about infection. So you want them to avoid tobacco use to decrease risk of infection. No bending, lifting more than 10 pounds, or twisting at the waist for 12 weeks. Now, they can start physical therapy after 6 weeks. However, there cannot be any manual manipulation of the SI joint. This could be more core strengthening exercises or pelvic floor exercises. Administration of prophylactic antibiotics, you know, it's up to the physician, but it's not supported. You know, there's no evidence that it should be done. As far as anticoagulation, I usually pick the most conservative between the NAC and ASRA guidelines, and all the anticoagulations can be started 24 hours after. If you know, if a complication is suspected, like infection or hitting a nerve, neurologic issues, let's say that you suspect that the implant has dislodged and popped out, immediately order an image. You could order some epilateral x-rays or CT. And then surgical incision site infection are more likely to occur 2 to 4 weeks after surgery. Now, if they have uncontrolled diabetes, they are on chemotherapy, they have autoimmune disease, usually these patients are on immunosuppressant medications or chronic steroid use, history of smoking, definitely look at their A1C and also look at their daily blood glucose levels. That's very important as well. And make sure, you know, these are very high increased risk of infection in these patients. All right. Thank you.
Thank you, Amir, for the presentation and joining the team tonight. And I think we're pretty good on time. So thank you everyone involved. And I think I have one more question in the Q&A box. And this is the question. I read it out loud. I have seen insurance refusing to cover sacral LBB RF for SI joint pain recently, despite temporary relief of SI joint injections. How have you found insurance coverage to be for the SI joint fusion? So basically, how are SI joint fusion covered currently from the insurance carriers? Who wants to take that on?
From my understanding, it's changing a lot as we speak. I think there was an issue with the code recently, but you know, I haven't had any issues with the insurance companies, even after start of this year, which was supposed to be much more problematic. Again, large population, our large population that we treat as Medicare AB, so which is more much easier to deal with, but it depends on what's the large insurance company you're dealing with. So if anyone else have anything to add to that.
I think recently the posterior approach is a T code, my understanding, and some things have in the last few months or maybe in the last few weeks where there was some concern about the physician fee getting paid, and I think that's been kind of teased out. I think the approach is not the T codes. I think my understanding is the lateral approach is kind of the standard posterior fusion kind of orthopedic code, and therefore maybe a little bit more straightforward to get covered if you do the posterior approach, which more pain physicians are probably comfortable with or familiar with, then you're going to have to use the T code, which I think does get paid off out, though it's just my understanding with T codes it's a little bit more complicated. It's less straightforward, though they are getting reimbursed.
Right. So I think that the bottom line is, as you both pointed out, and the question itself, you know, the reimbursement environment is challenging and is changing. So it depends a little bit also where you practice, what are the local and national coverage determinations, you know, what is the insurance carriers, do they have it covered or not? And if there is any pre-authorization process that you can basically ask for permission, and also depending if they allow it, you know, potentially negotiate with your reimbursement. It is challenging, again, SI joint fusion, especially the posterior approach, so please stay tuned. That's, again, the current environment we're practicing in, we as interventional pain physicians. And I think we can go to another question in the Q&A box, and I'll read it out loud. How can we find physicians who are offering endoscopic spine surgeries to refer to if you do not do those procedures? All right, that's a very good question. I think Dr. Kumar can answer that.
I can take that. I have taken a lot of cadaver labs. I've conducted cadaver labs for neurosurgeons and ortho spine surgeons. You know, they were either done through ASIP one time was like 2015, 2016, and the device companies, Reverse Spine and Eloquence, offer them. So personally, I've seen a lot of surgeons actually come to the labs. The question remains, and I was there at NAS conference this last year in Chicago, and still there was a big push by NAS because they are seeing the writing on the wall. They're seeing that worldwide, this is the preferred form of spine surgery. They're pushing surgeons to get out of their laziness and start adapting spine surgeries. It's tough to get out of the microscope habit where you have to use both. You can use both hands looking in the microscope and versus holding the endoscope. So surgeons are now being pushed to actually adapt to endoscopic spine surgery. So I'm pretty sure there would be somebody in your state or closer to an institution where you know, you can find somebody. You just have to Google them. There are a lot of spine institutes popping up right, left, and center. So I'm pretty sure you can find somebody. If not, the Eloquence company or the Revo Spine, these are the companies that manufacture these devices. Eloquence, you can reach out to the company reps and they'll be very happy to get you in touch with somebody closer to your institution who is doing these cases. In the worst case scenario, you can always refer them to University of Florida.
We're done. All right. Thank you for the answer. Well, let's see. There is no question left in the Q&A feature, and I also don't see anything in the chat box. And also thank you, Nick, for answering the question regarding radiographic measurements. I see a question in the chat box for the endoscopic spine fellowship. Yes, the requirements at UF is that you have successfully finished and graduated from a pain medicine fellowship. So that's a requirement. So that basically is a second year you would spend in training. Otherwise, I say again, thank you very much for joining us tonight. If I don't see any more questions, I think we can come to the end. And on behalf of ASRA Pain Medicine and the APPD, so that's the Association of Pain Program Directors, I would like to thank you for your participation in today's event. This concludes the ASRA Pain Medicine APPD Hot Topic webinar series for this academic year. And I hope I see you, or again, hopefully you'll be junior physicians practicing, but maybe also the next generation back in August, September of this year, starting with the new Hot Topic series. Again, thank you very much. And for the ones who are graduating, congratulations. Good luck with starting off into your job. I hope your visions come through. And also please stay engaged. That means, you know, we need your support and your advocacy for our patients and our specialty. Otherwise, we'll not be successful in the future. Again, thank you very much and good night.
Good night.